Hi, and hope you and your loved ones are safe and well, wherever you are. I'm Dr. Amin Kaboli, lecturer at EPFL, business consultant and executive coach, and I have the honor and privilege to discuss about the COVID-19 crisis management at CHUV, the case, which is the University Hospital in Lausanne, within Canton Vaud, the case of two medical departments with my dear guests, Dr. Antoine Garnier, Chief of Crisis Staff, Senior Attending Physician from Internal Medicine Department, and Dr. Olivier Gaide, Head of Onco-Dermatology Unit. Thank you, gentlemen, for joining me.
Hi, everybody. Thank you very much.
Well, thank you for being there. Hi to everybody.
Thank you. So to start with, how has COVID-19 changed the nature of what you do and how you do it?
I would say that COVID-19 crisis was about focusing on one single thing. We forget everything else. We just manage just to resolve one problem. It was COVID-19 for 3 months. We didn't think about something else than this crisis.
Yes, that's right. Everyone at the CHUV canceled their vacation. We were all on the bridge. It was a lot of extra work, some stress. But like everyone here in Switzerland, you had to live with it, with your kids at home suddenly, with a situation where you were maybe fearing for your loved ones, the family who was maybe at risk or thought to be at risk. So this all applied to us as well. We're not just physicians, we're also people.
Thank you, for sure. Yeah, thank you. And you guys were on the front line of this, let's say, battle or the fight against COVID-19 and supporting people. How COVID-19 touched your department? Anybody want to start?
Maybe I could start saying that, first of all, the internal medicine department just managed to hospitalize a lot of COVID-19 patients, and we had two main chapters. First chapter was increasing capacity from 150 beds to 250 beds, enough capacity to reach enough capacity to hospitalize all patients. And what we wanted is never being in a situation we have to restrict healthcare to all of people, to all of patients, COVID-19 or not. We were really concerned about how to continue to give the best medical care, either for COVID-19 patient or not, and having enough capacity to get all people hospitalized and care of was really the first interest, the first priority. The second chapter was if you open a lot of beds, additional beds, you have to find people staff and collaborators to care of this patient. That means doctors and nurses and everybody else that taking care of patient. And for that we had to hire a lot of doctors, and we with the cancellation of holidays at CHUV, that you maybe know that all holidays during the crisis were cancelled. And that means we had a lot of nurses available to care of additional patient. But that's not only about internal medicine department; it's also about the other department, because a lot of patients were cared by, for example, the orthopedic department. And so this is, we get an outstanding support of other department. So that was the two first thing I would like to say: increasing capacities to get to hospitalize more patients, and the outstanding work of collaborators, and with a lot of help of other departments, not just internal medicine department.
Thank you. How about you, Dr. Gaide?
So for us, it was kind of the opposite. Our first goal was to see that we would not bring to the hospital and a lot of patients that were at risk. So a lot of the patients that we follow for skin cancer are elderly patients, are immunocompromised patients, and our first concern was to stop the flow of patients into the hospital that come for ambulatory reasons, and who maybe were suddenly, because they were coming to the hospital, would be put at risk because they would be not in the car, but when they come by public transportation or when they wait in our waiting room, they would be exposed to other people. And we knew we wanted to have a maximum of social distancing between our patients, maximal social distancing between the physicians, the nurses, and the patients, and also between the physicians and the nurses between them, so that we would diminish the number of cases that would end up being, having to go, they would have to go to the internal medicine department, for one thing. Another thing is that we expected our physicians and nurses to fall sick, so we expected to have a diminished staff. And we also expected the same thing to happen in the internal medicine department. So we decided to make sure that we would have extra staff on the dermatology department that could go to the internal medicine department if needed. So it was a big effort to look at all the things we could, avoid doing, all the way we could empty the department so that we would keep a maximum of people at home for social distancing and a maximum of the staff ready to go to the internal medicine department to help. And just to give you an idea, we see between 5,000 and 6,000 patients a month. And we took that down to about 500.
In a regular term, yes?
In
a regular, let's say, month.
Yes, on a regular month, we see about 60,000 patients a year, meaning patient visit. Some patients come several times in the year, but it's to give you an idea. So it's about 5,000 per month. And we went down to 500.
Wow.
So that these patients would come basically in an empty waiting room, would have no waiting time. So the only person they would meet would be a physician or a nurse with a mask, practicing perfect hand hygiene and, limiting the risk to a minimum. Now, that being said, what we feared was that our very, very at-risk patients, the patients that have cancer on their skin and risk metastasis, would fear coming to the hospital so much that they would delay their treatment and end up being all the worse for that. So this was really a problem for us. And in order to avoid that, what we tried to do is to go through every single file that we planned to have at the hospital, in the months of March and April, decide whether this patient could wait 1 month, 2 months, 3 months, 4 months, and then call the patient and say, look, you are one of the patients we'd like to see. We've emptied, you will be alone in the hospital, but you should come. Or, when it was not needed, then we would ask for the patient to postpone their appointment, except if they thought they had something urgent to tell us.
I see. So what I see is from internal medicine, we have on that department, we have like increasing from 150, if I'm not wrong, to 250, which is 100%,
exactly
100 beds capacity, and a number of doctors, for example, for the 50 doctors, as far as I remember from the talk that we had, and other staffs, nurses and other collaborators, plus like canceling all of the holidays, exactly. And then from your side, the approach was a little bit different, freeing up capacity here to send collaborators and doctors to internal medicine. From the other side is just like decreasing the appointment and then seeing what are the most urgent appointments that or cases that you have to take care of to free up the capacity. Is that correct?
Yes, and part of it was also getting part of our staff doing telemedicine. And this way, avoiding contact, but also, you have to realize going through 5,000, patients' dossier in order to know which one has to come, which one can be delayed, takes a lot of time. a lot of time. That's a lot of work. And unfortunately, it's not something we can really show. We cannot say, look, we increased our visit, the number of visits. It's the contrary. We decreased the number of visits, and that costs us a lot of work.
Thank you. Is a valid point. So for telemedicine, would you please just elaborate more? How does that work right now? And because it's a trend that it came out. I mean, it was before, but COVID-19 definitely accelerated this trend.
Yes, absolutely. Yes. So telemedicine is something that we've been trying to set up at the CHUV for a long, long time. And there are several ways to do it. Telephone calls, emails are example. But of course, we want to go a little bit beyond that with applications. But there are a lot of issues in terms of the patient's identification and patient security. Because whatever we put in a patient's dossier online has to be, I mean, we have to be sure that really, this is really information that belongs to the right patient. And we have to make absolutely sure that it cannot be stolen. And of course, I mean, some solutions, as you well know, we would not use freely at the CHUV.
Exactly.
For telemedicine in the internal medicine department, that was the opposite, because starting the crisis, we told us, okay, we have to put a lot of staff at home because we didn't want to have a lot of staff sick. So we tried to do telemedicine, but it was only possible for one secretary staff per unit. We had maybe 10 or 15 people at home. All the other staff were on the bridge, had to work with the patient that's actually here. So, but for example, we also did it. It is possible to do it. For example, we had one member of our crisis staff, the doctors responsible for managing the human resource, was at home for every single day of the crisis. So it is possible to do all situation report with someone on. With someone at home, even if the person is very important. So we tried to do some telemedicine, but it was a very limited task.
Yeah, so dermatology is a very visual field where pictures sometimes tell us more than the patient can actually tell us. Not all the time. Most of the time, just like everyone else, we need a full patient history. We need to think, we need to see, we need to touch, we need to do biopsies. But there are some things that we can do using telemedicine. And so part of what we did during this crisis was to establish basically not protocols, but standardized emails that we could provide, that we could give to the patient, which explain exactly what we needed to know, what we needed to have, and what kind of picture we needed, how to take them. It can be very simple, very simple recommendations for taking a picture of the skin with a smartphone, like don't go close to the skin because then the picture is fuzzy. The resolution of your smartphone is so amazing that take a picture from far away. And then we have the vue d'ensemble, and also we can zoom in on the details. And then we are pretty good. I mean, we cannot, there's no way we can do everything like that, but we can do a lot. And we can also decide what is urgent and what's not urgent. So, and this information can be then transferred to applications because they're the same questions you're going to ask, whether you ask them in an email or you ask them in an app. The way you recommend taking a picture is the same whether you do it from your smartphone and then attach it to the email or whether it's directly embedded in the app. So we've moved forward quite a bit there, and we really hope that very soon we'll have a devoted application that will be very user-friendly and will help the patients have very quick advice on telemedicine. So we think this is going to stay. We think this is going to outlast the crisis.
Okay. That's very interesting. That's very interesting. Is there any applications that being used, or there's a hope that somebody develops an application?
So there are some commercial applications, but they are not hooked up to the CHUV. And I was hinting to the fact that one of the problem is who keeps the data. And the CHUV is really skeptical of having partners that even in Switzerland that have their own database with patients' records. And we are dedicated to having all the patients' data from the CHUV at the CHUV and with the utmost security.
Absolutely, which is the case for COVID app as well, which is all of the data of the user is going to be stored inside of the, let's say, device of the user, not being shared together, which is definitely patient security is at utmost importance. Regarding crisis management at CHUV, Canton Vaud was hit hardly, and I'm talking relatively for Switzerland, and we are number one on the number of mortality rate, let's say, and infection. And then I guess number 2 is Geneva, number 3 is Canton Zurich. So definitely the heat was high for CHUV, which is the university hospital, I believe largest hospital in Canton Vaud, right? Definitely yes. Then crisis management here is tougher. So how did you manage that all?
Yeah, first of all, I would say that we had a very good and extraordinary management at high level. The whole crisis was very well managed by the CEO. For what was at the beginning is the uncertainty. That we know that something's happening. Everybody saw what's happening in Italy and in China, and we started to be very anxious to say, okay, how will we be for us? What should we prepare? How much bed do we need? How much respiratory device do we need? That was the question. Nobody can answer that from one week to another week. So, for example, that the first week we hear that we should be able to admit 100 patients in one weekend. So that's a lot of people in one time. So we were really anxious, but something happened. Is that we get a lot of people with COVID-19 patients, but at the same time, there was a lot of other patients who didn't come to the hospital. So we could increase regularly the capacity, and we can manage the crisis without being overwhelmed.
I see.
But from the department perspective, we had to put a crisis management in place, because things going too fast to be based only on our regular government bodies. That means we did 3 things. The first thing we did is we create a crisis staff who didn't exist. The crisis staff is just all the chief and the head of the department. That's about 20 people, and we gave everyone just one field of responsibility, and we did it we put that in a staff. That means working in staff. So something that we don't do regularly. With sales and chief of sales and the situations report every day for 1 hour. So something very interesting, because at the beginning we didn't know what to do, or how much we have to prepare, but we were able every day to manage all the new information and the new task the department has to do. That was the first pillar. This was this creation of the crisis staff. Second was we identify the internet crisis communication as really a high priority. And at the time of speaking telemedicine, teleconferences, everybody at home, and there was a lot of emails. Everybody's talking to everyone. So with this overwhelming communication from the political, from the media, from the hospital, we choose to go face to face. So we base our internal crisis communication by every day at noon, huddle everybody together, face to face, just to tell, okay, that's the situation for the next 24 hours. That's the situation. That's what we have to do, and that's what also we were so able to hear from the front what's happening, what's the concern of our staff, what's the fear or not, what's the practical problem we have. So internal crisis communication was the second pillar, very important. The third one was we wanted to have a constant overview of the situation. And for that, not just only numbers to know how many people, how many patients, or how many beds, but also how collaborators, how does it feel? Is there any problem in a unit? Is there was a logistical problem? So we wanted to know that, and for that we put a tactical operation center in place, something like this, with just people calling all units 2 times a day. Okay, what's the situation? What's your situation? How many patients do you have? Do you have any problem with your staff? So, and with that we could take every day good decision. And what I'm really proud is that we could just take one step back to have the world picture, and don't forgetting the other patient, non-COVID-19. There is we didn't forget the caregivers, the families. We always have enough time to think about other things than COVID-19 in the hospitals.
Thank you.
So that was the three pillar of crisis management.
So if I understand it correctly, number one was a task force group, which consists the head of CHUV plus head of all departments. Second, probably tactical operations center, which is like a control tower, and then going for monitoring all the situation constantly. And the third one, like communication, internal and probably external, like with other stakeholders.
I think at two level, at the department level, there was people working in a crisis staff, and at the CHUV level, there was also a crisis organization with also a good staff, well organized, and enough to get information in and make decision out.
Excellent.
So.
Excellent.
This was not only about medicine. You're right. I mean, the whole CHUV, including people who buy protective equipment, for example, we're all part of the response. Maybe what I wanted to add is that it's true that in a normal standard situation, the CHUV is a huge company basically, and every department has to pull the blanket a little bit to their own side. You have to fight for money. It's not money is not falling from the sky. You have to ask for it. Exactly. When you get it, someone probably doesn't get it. And because we saw what happened in Italy, and this is every medical worker's nightmare is to be in a situation where you are going to have your patients dying, not because you could not do something, but because you don't have the resources, that you should have. And I think because of this, everybody realized that we would need to pull in the same rope. And I think that when you work in the medical field, you very often have to take difficult decisions that you discuss with other people. It can be colleagues from other disciplines, but it can also be the nurses who are specialized and work with you. And then you give orders, and these orders are followed. But if things don't go accordingly, you count on the nurses to come back to you and say, look, your treatment, it's not going the way we wanted, or this new element occurred. And I think that because of this, we're kind of used to crisis management on a medical level.
Exactly.
And that what we did really well was to put this kind of management, micromanagement and macromanagement at the level of the CHUV, if I can say so. And I think that it worked really well. What Antoine maybe didn't realize, because he was in the, really the heart of the department and the crisis management, but what we had more a bit more remote from this place could observe was that there was a lot of trust from this crisis management group. And they gave us a lot of freedom. They said, okay, you're the pro. What do you think you need to do? But tell us, we want to know what you do. It was not like, okay, do what you think is best, but it was really organize yourself, be ready to do the best you can. And because we could do this very efficiently, I think we gained a lot of time. There was no, you didn't have to file a report and then wait for 3 days because it had to go up all the normal echelons to the decider who then would put it back down. No, it was basically, okay, this sounds like a very good idea, you go, you do it. And this helped us to be very efficient, I think.
So they decreased kind of hierarchy in a way that, and gave a lot of autonomy and independence, while it's being checked with, let's call it, tactical operation center.
Yes.
Which was just like all of them back and forth checked, and properly everybody had the freedom to move, right?
Yes, and of course, I mean, the idea was to let the management know what forces were available to them. But when we said, okay, this is what we need to do in order to provide people who are at home and are ready to go, then they let us do it, and it worked.
Yeah, there are 2 points. I have a very good question I received from the audience. I would mention this very soon, but there are 2 points. One is I haven't heard or I haven't seen any report that we face the same as, for example, UK, United States. We haven't faced any lack of PPE here, personal protective equipment, mask or gown or any kind of any other protective equipment for medical staff. Is that the case?
That's totally the case. We didn't miss. We didn't miss it. That was a challenge for the logistic. Yeah. Not to get supply for today, but to get supply for 1 month ahead. That means at the beginning of the crisis, we had to be sure that in no case we will have to take care of COVID-19 patient without mask.
Exactly.
So if this situation was never the case. No single days we had to take care of people without protection. Yeah. But at the beginning, it was, you see that it was not all the measures at one time. It was progressively. We start to cancel the visits, and the next week we put another measure. But the CHUV had to be sure that we have enough supply to don't getting short of mask in the next few weeks. And the other thing is, we had to be sure that it was not only CHUV, but also the other hospital in Vaud or Geneva in Switzerland, that the decision of putting mask on everybody's face was the same decision for all hospitals. You have to be coherent. You have to be the same decision. That was a little challenging at the beginning. it's not black or white. It's not because you have a mask, you're protected, and you don't have, you're not protected, and you get every time a COVID-19. Distanciation is also important. Is if you have 2 meters between people, you don't need a mask. But I would say that the concern of the hospital at the beginning was to be sure that the staff could take care of COVID-19 patient with protection every time.
Mm-hmm.
And the additional measure we took were to thinking that the patient are vulnerable people, and we have to protect them. That's why that was the reason to put a mask on on everyone's face.
I see.
And but yeah, that was challenging. We didn't wait on the mask. We wait that the supplies for the mask were secured, and after that, the CHUV take the right decision to be to don't think alone and saying, okay, at CHUV we have masks, but we don't have in Geneva, for example. But
exactly.
Because that nobody would understand. But that was not every day. We have some days we have to explain why we have mask or not, and what was the measures, and that was not easy. And that's why the internal crisis communication is so important. Is
absolutely
because facing uncertainty, you have to be able to explain, or saying we don't know.
Yeah.
Okay.
Yeah, so, I must say that this was very appreciated, to have this kind of transparency and receive regular emails. Okay, this is the situation. This is where the internal medicine department is at right now. This is how many patients we have under an intensive care unit. This is how many, do we have enough PPE for the next week? You know, that really helped us go on and you know, feel part of the team. And it, yeah, because we were scared at the beginning that we would not have enough masks, for example. Exactly. I remember that during the first week, we realized that a lot of patients were leaving with full boxes of masks, 50 piece that they were basically stealing from the hospital. So we had to put them under lock. That's the way it is. But just to make sure that we would have a rational use, as rational as possible.
Exactly.
Because we realized right away that we might not have the stock to just give them to everyone and just burn through them like if they were nothing.
No, it's a great case of supply chain here. First of all, for the procurement, it was enough supply, or of course, in any supply chain, we have disruption, but managed properly. The other thing is matter of communication between other hospitals to avoid any competition for a stock or for the supply line. I believe all of the masks or other that comes from South Korea or China, and we had disruption because there were lack of, let's say, flight or supply or limited supply for the whole world. And that was the case for NHS, for UK, or for United States. So as of that, we had enough supply and proper communication from the crisis management team. So my main question here, I'm going to shift from the management and process to human side. So we haven't lost, hopefully, I haven't heard anything. We haven't lost any medical staff or doctor, nurses while dealing with COVID-19 patients, right? We don't have any case in CHUV.
No. At the beginning, we did scenarios to get prepared, and we told us, okay, there is two things that will happen. We will have too many patients to one side, and not enough collaborators, not enough staff on the other side, because they are also sick. And we did scenarios with I don't know, minus 25% of staff. What should we do? How shall we care patient with less people? Fortunately, it didn't happen. We had a very low rate of sickness, COVID-19 or not. Everybody, every staff and I think there was a lot of staff that were sick is because they get COVID-19 outside of the hospital, not inside. But and maybe we could say that with the communication, with a very good protection process, with some that people are feeling good at this time, not stress, and maybe the environment was important. And at the end, at the bottom line, we didn't have more than 2% people sick. That's why, or maybe 50 people for a staff of 600 people. So not a lot of people were sick. We didn't lose anyone. We didn't have somebody really sick, badly sick. So that was very, very satisfying at the end. That was not the case everywhere, because there was always a department where they get 1 people sick, and then and then 10 people getting patient or staff getting sick of COVID-19. So that's the cluster. We were really every day afraid of having cluster in our department, but it didn't happen. Maybe by luck, maybe by good management, I don't know, but
it's
we
definitely
really
a combination. It's a combination of this relative success. To just give for audience a perspective, it's sad to know that 300 people we have lost in UK in NHS general system. A very good question. While we were talking about people, we stay there, and there's a very good question from the audience. I really appreciate, this is the quote from the audience and question. I really appreciate the work of health workers like you during this crisis. Did you have to deal with burnouts and anxiety of being on the front line?
Yeah.
If yes, how?
Maybe Olivier will start to answer this question, but I have something to answer.
Yeah, so there was a lot of stress. There was a lot of stress because of mainly of the anxiety of the unknown. And once you have your plans ready, once you have your contingency ready, you say, okay, well, now we're as ready as we can, and we're going to do our work the way we can. And as time progressed, and as you see that because of the transparent information we received, as we already discussed, but that your colleagues are not falling sick, that your colleagues are not missing time, then you gain confidence that what you're doing is right. And at some point we realized, okay, we're going to go through this, and we're going to do it pretty well. It's not going to be like Italy, and then the stress left. But there was some stress, but burnout, we didn't suffer in the dermatology department. So nobody left because there was too much stress. So we were resilient enough to actually be able to deal with the stress.
From outside, I would totally agree. And maybe there was this effect that everyone was on the bridge, understanding what is his position, what he should do. And so everybody was very motivated, and we didn't have any burnout during the crisis. I would say that it's not that easy, because if we speak at we did a lot of debriefing session, and to get all experiences of this crisis. Everything inside the hospital, everybody told, it's great. We didn't have had problem when we were at the hospital, but we do not have to forget about people living crisis also outside the hospital, and this part you don't see at work, because everybody's working, everything's fine, everybody's happy to get the right thing, but you don't have to forget what's happening outside, and everybody has families and friends, and people sick or not, or people they don't see because of the confinement of the so it's not that easy. I would be very humble to say that everything's fine. I don't think so, but people had more to. I think in our department, a lot of people had to deal more with something outside the hospital and as human being, and not inside the hospital. So you don't see somebody crying in the units, but I don't think it could be the case outside.
Exactly.
So what we did in terms of micromanagement was to make sure that we would talk to the people who stayed at home, who were doing telemedicine every day. So we would call them and say, "Oh, hi, how are you doing?" You know, I'm not calling about the job. I'm just asking, how are you? How is your family? Do you have loved ones that are sick? Do you have loved ones abroad? We have a lot of our interns come from Italy or from Greece or from other areas of Europe. You know, what's the situation in your country? Do you fear for them? When was the last time you saw them? And so we try to maintain the human touch. But as Antoine said, once you're in the hospital, you know, it's a busy day and you're part of a great thing, which is moving forward. And so it really helps. But we feared that those that were staying at home could, you know, fall under the radar and suddenly have you know, a burnout. And luckily for us, and again, it may be a question of luck or good management, but probably luck, it didn't happen.
Thank you. Well, let's say scientifically, if we see, definitely the chance is there, but then we decrease the chance of burnout by what you say is creating psychological safety, creating a secure base for the others, having bond and connection with the others, and keeping everybody as an extended family. This definitely creates, puts people at ease, and all collaborators, and they are proud to be part of a greater movement. But we were relatively successful, and thanks to all of you gentlemen and all of your collaborators, it was a great job so far. But are we done with COVID-19 first wave? Probably we have second wave or third wave. How do you see that?
I think I'm not the right people to make a prediction, and so we don't do any prediction. It's not the right thing to do. We could just do scenarios to get prepared. That means what should we do if this happen, or if it happened this way, and if it doesn't happen, it's not a problem. So basically, now what we did after this first wave is making a contingency plan to be able to respond to the second wave. And a second wave, I could say that one for sure is that it won't be the same. It won't be the same things. It won't be the same concern, the same issues. And I think a lot of things will be different. We will, you know, for example, if you, we will maybe have more clusters and clusters that it won't be, for example, just one peak of infection with a lot of people, but something more in during more weeks, maybe, and maybe the staff, the people, the caregivers will be different. Everybody was happy to take to cancel holidays for the first wave. I don't think it will be the case for the second wave. They will ask, why should we? There will be more question. I don't know. So one for sure is it won't be the same. It won't be, and I think it will be more complicated to manage, because if everybody in the first wave were ready to do everything for the COVID-19 problem, maybe it won't be the case for the second wave.
So our view is that yeah, we're done with the first wave. I mean, it went up, and when it went down to almost zero, so basically that's the definition of a wave. What we're sure is that COVID-19 is still here. that everybody agrees on. And it's going to be here for a few months for sure. At least until we have a good vaccine or we have herd immunity. But certainly for the next few months, it's going to be here. So the effort that we made for the first wave, we cannot sustain forever. Yeah, so we're extremely happy that it went down. And now we have some breathing time. And we could allow some of our staff to go on vacation and recharge the batteries and get ready for the second wave if it comes. And I completely agree with Antoine. Maybe we won't be that happy to cancel our vacation, but at least we've had vacations before we cancel the next ones. And that's a huge difference. If you don't allow the medical staff to actually, sometimes have a breathing time, you will go to burnouts. You cannot just say, oh, you know what? We realize that for 3 months, they don't need vacation. Let's do it for 3 years. That it's not the same thing. So we made a huge effort, but now we deserve, like everyone else in Switzerland, to have some easy time. And because of this, we'd really want people to social distance, be careful, and not just think that this is over, we can party, we can forget about it. The first wave was the only wave. No, for us, we have to think that a second wave is on the horizon. We certainly hope that it's not going to come, but we have to prepare for it. And that includes people, not outside of the hospital, just changing their way of thinking and just practicing what we all do: social distancing, masks, quarantine if needed.
So these are the strategies. Of course, in business, we always try to increase the demand. Here in healthcare, we definitely try to decrease the number of infected people, which right now it is the case. We have like around 100 by average. If you see with the last 2 weeks or 3 weeks, we have in Switzerland, per canton is going to be 2 or 3 infected, like tested and infected. Probably there are some people that they are not tested. This is another cluster. But then this number, we are decreasing the demand. This definitely part of it that helps the healthcare staff there in Switzerland, and specifically at CHUV. And then, as you mentioned, some activities like social distancing, washing the hand constantly, wearing masks in public places, contact tracing. That would help, contact tracing as well, because it's not going to be effective if less than 40 or 50% of people in Switzerland, they use it. So everybody, more or less, they need to use it. But that's another strategy. But how else people can help the guardian of their cities? Doctors and nurses.
Well, you mentioned, basically what you do in business, and so may surprise you, but what we want is actually to have the least people sick, so that those that are sick, we can have big needs and we can do great medicine. And we don't need pandemics. We really don't need pandemics. We have plenty to do when there are no pandemics. We don't need epidemic, by the way, either. We don't need infections. We're great without them.
Endemic as well there. We don't need that as well.
Exactly. So it's really, when you do these things, it's small things. And that includes, as you said, contact tracing, which is helped by applications, which can also be done by people talking with people who are positive, tracing their contacts through other means, and contacting people they have been in contact with, and so on. It doesn't only rely on applications that people may or may not have. Mm-hmm. The problem is that when the system is overrun, contact tracing doesn't work anymore, because you don't have enough people to call all the people. When there are too many people, you cannot all quarantine them. And sometimes if you think that 90% of the people will freely quarantine, but some will not, either because they don't know or because they don't want to, or they don't do it as well as they should, then after a certain point, that the virus will reemerge at a frequency which is too high for us to take care of easily.
Exactly.
And that's what we're doing, what we're seeing in other countries. So it's not the case now. We were very happy about that. And we really encourage people to do what they've been doing during the last weeks, because it looks like it's working. So we don't want people to drop their defense.
Thank you. Dr. Garnier, what is your view on that?
I think Olivier is totally agree about his analysis of the contact tracing. I would just say that there is no one things that work.
Absolutely.
If they think that having or not the contact tracing application in your smartphone will protect you, I think that's not the case. And maybe the people who have the application on the smartphone are the people who just respect the distanciation and protection measures. So I don't know, but I think that it's a wall. It's because we have this application plus the health policy plus the society behavior. So it's because we have all that we are able to fight against the second wave, and definitely the second wave will be defined because of our because we could not continue to trace everyone and to have everyone on quarantine.
Exactly.
So I think there is no question. This application is what we need is one tool on our crisis management or pandemic management for now, and it's very important to have it.
But what I get from both of you is that the core is social responsibility. And these are the approaches all around that people, they have to use it in combination, not just one, like as an app or just mask, not washing hand, because then again, by surface, you can get it. So it's an aerosol virus. Definitely we have to have different combination of different approaches, but at the heart is social responsibility. Yeah. We have a question again from the audience. Is CHUV in a stable situation or well prepared right now? Or do you feel that there is still work to be done? I believe it's about crisis management. Like, regarding crisis management, are we in a stable situation? Which partially you answered, Dr. Garnier.
The CHUV is totally stable for now. I mean, we don't have any concern about what's happening now. Mm-hmm. All the measures we have, for example, putting masks on people getting in the hospital, having people controlling the entrance. No, it's not a problem. Everything's fine. I would say that if we think that everything is fine, we also learn a lot of things from the crisis. We spend times to see what should we do. What should we do next? How should we do it? What should we keep as good things that we happened during the crisis? What should we do better? There was a lot of things, and not that is at our level, department level, or for the hospital level. So we learn every day. So we have some luck. We were not alone. And we were not alone in this crisis, because also we have also the health policy and the decision of the canton or of the other hospitals. So we were not alone, but we have to learn about what we did to be better for a second wave, for example, but also outside the pandemic. For our process. I think one thing we show in the hospital at CHUV is despite a huge structure with a lot of people working, we were able to be we show some agility during the pandemics, during the crisis, the past few months. We show that it is possible to change things fast and efficiently, and we could do that. We can do that. So that's the very positive learnings of this crisis. But we also have a lot of things to improve. So,
of course. But thank you very much. Let me ask Dr. Gaide, what do you think? What are the takeaway lessons from this crisis? What do you, in your view?
Well, I think what Antoine said was very important, that we found out that the CHUV could be pretty nimble and agile. And I thought it would be the case, but I wasn't sure. This is why we don't feel cocky now. There's still a lot to be done. I think there have been a few things we could have done much better. But I feel safer, not safer, but I feel more confident now about the capacity of the CHUV to answer to this type of crisis than I would, even if you had asked me 6 months ago, what about a pandemic like the 1918 flu? And I'm not sure I would have told you that we were completely ready and that we would do great. I think that we realized that we came relatively close to the limit of what the CHUV could offer in terms of beds. I mean, we were not close, but we could see the point where we thought, okay, if things continue the bad way, then maybe in 2 or 3 weeks we're at the limit. And this did not occur, so we're very happy about that. But we realized that we can really move fast when we want to, and that feels great. But I wouldn't say that we feel like okay, that's good. Now we're good for the next 100 years. There will be we need to keep this momentum going, and I think we have. As Antoine said, we didn't come back to things as usual. We're working in terms of numbers like we used to. We're seeing the same number of patients, but the way we see them is not exactly the same, and really comprises all the measures that are needed to avoid creating situations of viral transmission. So I think we're doing a lot better in terms of the hygiene chain. And I think that I'm always hoping that this will even have an impact on other infectious diseases like the flu this autumn.
I hope so. So generally what I get is we learned and the case that it helped for relative success that we had, it was like policy, health policy and decision makers and society, all they had a kind of unity and support and integration. And you probably didn't feel alone. Internal communication, other factor that was there, professionalism, proper, let's say, supply line of PPE there, and support. What else? Leadership, creating the safety net and psychological safety, and keeping the bond during this crisis, and proper planning, right? I really appreciate, and personally, I've been touched, not necessarily at 9 p.m., like coming out and clapping for you, gentlemen, all of your colleagues, but truly I have a deep sense of appreciation and gratitude for all you have done and all you will, and what you're doing, and you will still support your city and your people. We really appreciate that. Thank you, guys.
No, thank you.
Thank you. Thank you very much.
Is there any point, any thought, last point that you would like to share with us?
I would just maybe add one thing is during the crisis, I think everywhere you see that the silos are getting down, and one silo we try to get down is making doctors and nurses working together, and this collaboration, we try to do that at every level of the hospital. And the crisis for us was one incentive to get people closer, working closer, better understanding what's the work of each other. This is one important thing that I would like to mention.
Thank you. Dr. Gaide.
Yeah, well, I think, we were helped by the public. The general public in Switzerland, they really did really well. And I want to thank them because this really helped us too.
Thank you very much. I can't be more grateful by the time and the opportunity that you provided and all of the insights that you shared. And I hope you have some days to rest a little bit and recharge the batteries. And I hope you're not going to experience the second wave.
Yep.
Thank you.
We'll see.
Thank you. So have a nice day. Take care.
Bye.
Thank you.
Bye.
Take care. Bye-bye.